شباب السلام عليكم. Welcome in weekly academic day. Sudanese Medical Specialization Board. Today we'll discuss about pneumothorax. And as you know, this is very common presentation and serious presentation. So you need just to be aware about the pneumothorax, tension pneumothorax, pneumothorax, then how to manage in the emergency department. And how to discharge one patient, be discharged one patient, be admitted. I will not cover all the aspect of pneumothorax. I will go just giving highlights about the important point in pneumothorax, because I think our lecture will be not more than 1.5 hours. So we need to be I need to be concise. And also it will be an interactive lecture. So I need your participation in the discussion, giving questions, sharing comment, concern. It will reach the discussion and it will reach the lecture. So pneumothorax, I think we can start now. Number is okay. So before going deep and dive in pneumothorax, just we need to highlight about pneumothorax and secondary pneumothorax. Anyone can participate in the difference between the pneumothorax, primary and secondary. What the difference? Primary pneumothorax, secondary pneumothorax. Your participation. يا شباب. Primary, secondary pneumothorax. What's the difference? You can write in the comment, no problem. Or you can open the mic and share your voice. طيب روان صديق قالت primary occur without underlying lung disease. Okay, good. Primary pneumothorax is that uh, there is no underlying disease causing this pneumothorax. It's very important to differentiate, because this is very important in management, in diagnosis management. It's very important in discharge admission of the patient. Very important to know it is primary pneumothorax or secondary pneumothorax. So primary pneumothorax, the cause of
السلام عليكم.
pneumothorax. نسمع.
البرايمري نيموثوركس بيكون في الهيلثي نورمال لنج،
Yes,
يعني مثلا
exactly.
البيشنتس اللي بيجوا RTA، البيشنتس بتاع RTA مثلا. لكن النيموثوركس ممكن يكون بيشنت مثلا بتاع COPD أو pulmonary fibrosis أو كده، وعمل له بعد ذاك النيموثوركس.
Yes, exactly, Islam. Primary pneumothorax, as Islam said and Rawal said, and also I think share also in the comment. Anyway, primary pneumothorax, as you said, the lung is clear. The cause of pneumothorax is not directly related to the lung tissue parenchyma or lung disease. And this example of like traumatic pneumothorax, it is primary pneumothorax, not related to the, just to give you example and the vision to be clear. Secondary pneumothorax, the cause of pneumothorax is directly related to the lung. There is clog in the lung. Whenever this cause is like asthma, for example, okay, congenital disease of the lung, for example. Okay, this is the coding of pneumothorax. It's very important, very important. Because when you know this is primary pneumothorax, the management is quite different, and the consequence of the disease, disposition, discharge, admission is quite different. between the primary pneumothorax and secondary pneumothorax. This is very expected. If any question or any comments in this area, yes, you can raise your hand talking, or you can chat in the box. Okay. um, as we said, primary pneumothorax, that means you have clear lung. The cause is not related to the lung. So, what are the causes of secondary pneumothorax? This is the cause of secondary pneumothorax, and this table is directly I copy pasted from Tim Tinali. A lot of causes of secondary pneumothorax, as you see in the table, related to the airway, related to interstitial tissues, and it may be also related to the infection, connective tissue disease, and cancer. So you need just to rule out these causes immediately when you find an pneumothorax in any patient. Just to rule out this patient had asthma, cystic fibrosis, because as you know, the management of pneumothorax is depend on the underlying cause. Underlying cause causing this pneumothorax. This will help in the management of pneumothorax that you need to rule out first, then to determine the cause, and then to intervene. So the most important thing, as you know, for you as emergency physician, is the tension pneumothorax. So you need to know about the clinical hallmarks of the tension pneumothorax. I need your participation in the answering of this question. What are the cardinal signs of tension pneumothorax? Specific signs in the tension pneumothorax. If you find the patient clinically, you immediately go and do in the second intercostal space, mid-clavicular line, you will do needle thoracostomy. So what are the um, clinical signs, specific clinical sign to pneumothorax? There is a lot of clinical signs for tension pneumothorax, but you need to know the specific tension pneumothorax clinical signs. Huh? Anyone can participate? Let me see the chat, if anyone chat in the box. Hmm. It's very simple. It's very simple. But I need you to be specific. It is common question. Tension pneumothorax, since we are medical student, we know that the tension pneumothorax and the clinical sign of tension pneumothorax. But as you are emergency physician, you need to be more specific regarding what exactly clinical remarks or hallmarks for tension pneumothorax. روان محمد.
hemodynamic instability by means of low blood pressure or hypoxia and bradycardia or tachycardia more than 120.
Tachycardic, yeah, hemodynamic instability, hypotension.
ايوه بلس هو الفايندنج بتاعت النيموثوركس اللي هو absence of air same side tracheal deviation.
Exactly. هي لأنها because it is a lot of sign of tension pneumothorax, and also it may be overlapped by cardiac tamponade. Hemodynamic unstable patient in tension pneumothorax, usually there is hemodynamic instability, and the specific signs for the tension pneumothorax you mentioned, Hussam, is tracheal deviation. This is very specific for tension pneumothorax. Hypotension is very also specific for tension pneumothorax. This is, but you mentioned more than 10, more than 8, I think, clinical sign for this tension pneumothorax. Let me just review. Tracheal deviation, as we said before, this is very specific for tension pneumothorax. If you find any patient you are suspecting tension pneumothorax and you find tracheal deviation, sure, deviation away from the site of the tension pneumothorax. So you need to go ahead and to do intervention. Distended neck vein mentioned by Irene Taufik. Distended neck veins can be also seen in congestive heart failure. Okay, so we need something be more specific to the hint. Hamid said in the chat, hypotension raise JVP tracheal deviation. Until now we are so hypertension. Now anyone mention hypertension, which is very specific, and this is the evidence-based studies and evidence-based medicine link it to the tension pneumothorax. Sure, RS JVB link it to the tension pneumothorax, but it may be less specific. So hypertension, very important.
Reduce chest
Hypotension,
expansion.
excuse me,
Reduce chest expansion.
reduce chest expansion, yes, maybe also. But we need clinical, very specific links to
Absent breath sound.
absent breath sound. Okay, profoundly. This is a four clinical signs for the tension pneumothorax. You need to remember it. You need to memorize it. You can check this four and save it because it can come in the question. It can come in the best of five, best of four. Decrease air entry abulgasm, I mean, like, but it's not like very specific to tension pneumothorax. Those four clinical signs are very specific to tension pneumothorax. And the question in the exam may come like one of the following very specific presentation, very specific sign for patient with tension pneumothorax. And he can put tracheal deviation, for example, put hypoxia, descended neck vein, and raised JVB. So by sure, you will choose tracheal deviation. It's very important to know about and very important to memorize intention pneumothorax. So diagnosis. It is very important to diagnose. Now we are, for example, you have one patient, tracheal deviation and hyperresonance and anything there, clinical signs. And then you did this chest X-ray. So chest X-ray in the right screen. Let us start with just X-ray in the right screen. Just I need someone just to interpret it, what he see or what she observe in the right X-ray. This X-ray, what do you see?
Bilateral pneumothorax.
Very, 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 very good. Very good, Husam. It's bilateral pneumothorax for sure. Bilateral pneumothorax for sure. So for the junior in R1, just we need to share some knowledge and some finding. So I'm just to elaborate why it is bilateral pneumothorax and why not. Rowan said absent lung margin bilaterally. One of the finding I can diagnose the pneumothorax is absent lung margin. I like this. It's better Rowan to say this is absent lung tissue finding. This, for example, in the left side, this is a lung margin or lung tissue, and as you see, there is absent like no lung tissue. You can compare this lung tissue. This talk for the junior just to know about. This is lung tissue. It's quite visible here, but here is not available. No lung tissue here. So this is the first
Yes, by the presence of
finding.
the visceral pleural line.
Excuse me again.
The presence of the visceral pleural line.
Yes, yes. You target this, yeah. This line, yeah. This
And
is
the
very quiet.
lung collapse.
Yeah, exactly. It's lung collapse. Actually, lung is collapsing here. This is the lung now, and also this is the lung now. Okay, lung should be like, as you know here. This should be the lung, but the lung collapse in this area and lung collapse in this area. So this is the finding. This is the second or third finding. Visible pleural line, absent lung tissue, absent lung margin, for example, then collapsed lung. What next? Very important sign here in the very important sign. It is quite clear here, although bilateral costophrenic angle, deep sulcus line, very good, Noah. Deep sulcus line, very good. You need to comment about this. Deep sulcus line. Actually, in the pneumothorax affected side, the costophrenic angle, it will be like the shadow, the black shadow, it will be more visible than patient with normal lung without pneumothorax. For example, you can see here, even you cannot even see any costophrenic angle clear. Not like this. Here is clear costophrenic angle because this is normal lung in this area, but here no. Here there is very, very, very obvious costophrenic angle. So this is commonly found in patients with pneumothorax. Very important to know. Very good. I think this is the time. Very simple to diagnose pneumothorax. Very simple and very easy. Lung collapse, absent lung tissue in the affected side, visible pleural line, and deep sulcus line. This is so this about the image in the right side. So what about this image? Anyone can diagnose what's here? Same finding. Also pneumothorax.
Right side. Massive
Right side.
pneumothorax.
Right side massive pneumothorax. Any other ideas? Any other comments? You
Right
agree?
side, large bully. Right side, large bully with hydrothorax.
Yeah, Wissam, you're right. That is why I put this pulley with the pneumothorax X-ray because it is very similar, and looks like massive pneumothorax as mentioned before. So how I can differentiate between the pulley and the pneumothorax? This is the question. Here absent lung tissue, same like here, also here absent lung tissue. There is no lung tissue here. Okay. Lung collapse, also there is lung collapse. I think all the lungs now here. So how I can differentiate between the pneumothorax finding in the chest X-ray and the balding? How?
Observing the two X-rays and the lung tissue in the pneumothorax goes parallel with the chest wall. In the bully, it goes like more concave.
Okay. One of the finding, you are right, Asia. But to be more specific, always the pleural line you see here is coming longitudinal. Okay, always in pneumothorax, and always the margin here in the pulley it come concave. Always. This is typical presentation of patient with pulley, and it is massive pulley. Always it is concave. This is the very thing. Between the margin, if we said this is pleural margin, or if we said this is pulley margin, it will come concave, and in the pneumothorax always it come directly longitudinal. This is the first different. The second is, I think there is 3 or 4 different. You can differentiate between the pulley and the pneumothorax, and it is very important to know about, because if you introduce just you to the patient with pulley, this will cause significant damage to the lung tissue and will convert the pulley to the tension pneumothorax or the simple pneumothorax. So it is very important to differentiate between both pulley and pneumothorax. The first finding is that concave margin versus straight pleural margin in the pneumothorax. The second is air fluid level in the body. Can you explain more, Noha? Nujud said pleural line. Yeah, we discussed now about the pleural line and concave appearance in the pulley versus straight appearance in the pneumothorax. There is finding here, air fluid. Yes, you are right. There is finding in the chest X-ray. There is now air fluid, but we are talking in general. What is the difference between the pulley finding and the pneumothorax in general? We are talking about lung collapse in both, absent lung tissue in both. Then always, always the pneumothorax occupy more than one segment in the lung. This is always like this. It may be 1 segment, 2 segment, 3 segment. But in the pulley, this pulley, because it is massive pulley, you can see it's very massive. Like it may be 2 segments, it may be 1 segment, just collapse other segments. But always the pulley occupy 1 segment, because it is like just a localized disease, not like pneumothorax. Pneumothorax can be extended more than one area in the lung, because there is no margin in the pneumothorax. But the pulley, there is margin and always occupy, not crossing more than 1 or 2 segments. So it is very important to know about the pulley and the pneumothorax. Then patient history, it will give you a clue regarding what's happening. Patient history is very important. You will take history from the patient, what is going. Some patient, they have a recurrent history of pulley. Some patient, no. Some patient also may have congenital causes for the pulley. Also, other patient also may not have. So the history, the examination is the same. Same. You can find hyperresident, you can find absent hereditary, affected site, and this. And if it is very massive in the upper segment, it may cause tracheal deviation, but it's unlikely pulley to cause tracheal deviation. Unlikely. Okay. So this is a difference. Deep sulcus line is absent in the pulley. This is very important, because we said in the first image The deep sulcus line is very specific to the pneumothorax. You need to know about it. You need to memorize it. So in the pulley, there is no deep sulcus line. As you see here, even because just now she said like air fluid level. You cannot observe any clear cost-of-running angle. So it is very important, specifically for R1, you need to differentiate. You need to be aware. You need to be confident in differentiating between the pulley and the pneumothorax. And as I said before, I think in the Durman Military Hospital, one patient is large pulley. They introduce chest tube, I think, and patient going in significant deterioration. So it's very important to know about. This is the diagnosis. Okay, go ahead. How I can measure the size of pneumothorax? How I can measure the size of pneumothorax? Aisha said bully is interparenchymal within the lung tissue. Yes, we talk about this, and we said this is segmental finding. Always bully in the segmental, one segment in the lung. So how I can measure the size of pneumothorax? Anyone can participate from your practice? Do you measure the size, and how you can measure the size? Please, you can share in the chat, or you can open the mic and on top. How I can measure the size? Very important. Very, 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 very important. Why you need to measure the size? Because the size will give you estimation about the severity of the pneumothorax. It is large pneumothorax or it is a small pneumothorax, mild, moderate, severe. And this also guide you to the management. How you can manage the patient without knowing the severity of pneumothorax. Just please share your experience regarding how you are measuring the size in the department.
طيب احنا بنعمل نشوف عدد السنتيمترات how many centimeters between chest wall لللنج تيشو او للبلورال لاين. إذا قسناه في الحتة بتاعت الأبيكس وكان أقل من 3 سنتيمتر ده يعتبر small pneumothorax. أكتر من 3 سنتيمتر this is a large pneumothorax. إذا قسناه في الحتة بتاعت الchest wall قصاد الهايلم أقل من 2 سنتيمتر دي small pneumothorax. أكتر من 2 سنتيمتر دي large pneumothorax.
That's all right. Very good. Very good, Asi. Last one is the light index. Okay. Very good. Thank you. Thank you, Asi, indeed. So the first one mentioned by Asia is the American College of Chest Physician maneuver, how they can measure the size. Actually, they are measuring the size from the apex, as you see here, from this point, okay, then to this point. Okay, you can see this is the lung. This is the lung. Okay, collapsed lung. This is the margin of the lung. Okay, you can see this is the apex of the lung margin. Then the copula, or you can say the chest wall here. You can measure easy by centimeter. If more than 3 centimeter, you can say this is a large pneumothorax. This is only two classification, either large or small. So you can say this large pneumothorax. Okay. This is the very thing. This is according to American College of Chest Physicians. Okay. Also, you mentioned intentional. Is it there? The second one is British Thoracic Society maneuver. And British Thoracic Society maneuver, it's measuring measuring from this point. This I will use same pink, this pink line. This is the margin. This is interpallular distance, but crossing the hilum, you need to be here against the hilum. Okay, just to measure. Sorry. Then here, just wall margin, pallural line. Then you will check. And the BTS use 2 centimeter. If it is less than 2 centimeter, this is a small pneumothorax. If it is more than 2 centimeter, this is large pneumothorax. This is so easy. There is another equation called light index. This is another equation. This measures the collapsed lung diameter here, and then the diameter of all the thorax. And there is equation. This is equation. You will apply this equation, and then it will give you the size, and it is same. Large pneumothorax or small pneumothorax. This is very important, and it is just an estimation. It is very good for you to classify and to categorize the pneumothorax in a matter of management and disposition. Okay. Very important ultrasound. Very important. Ultrasound in pneumothorax. Anyone can interpret this image? What you see in this image? It is normal or abnormal? Specifically, be here. Normal or abnormal?
Yes, I would say this is a normal ultrasound.
Very good. Very good. What is sign in the ultrasound? You know? What about the
The
sign in the
visible
ultrasound?
seashore sign.
Yeah, thank you.
Yeah.
Actually, this is the M mode, as you see. This is the M mode, okay? You will bring your ultrasound for patient suspected pneumothorax. You will use the liner or the abdominal probe, okay? You will put the abdominal probe longitudinal between the ribs. Then you will see this finding. Okay, this is pleural line. This is pleural line. Okay, this is the normal. You will see this normal. It is called sea shower sign. You are using ultrasound, Asia?
Yes.
Where you are working?
Port Sudan, Osman
Port
Digna
Sudan?
Referral Hospital. Yes. I used to work in Osman Digna Referral Hospital.
اوكي، عايز اشوف لكم صورة عشان بس اشيرها معاكم. اوكي. Anyway, this is the lung tissue. This is the lung, and this is the chest wall. Okay. This is the normal. It is so easy, so easy. Bring the ultrasound, use abdominal probe, put in the it starts from the upper zone, middle zone, lower zone, put in the upper zone bilaterally or at the area of pneumothorax. Put your abdominal probe between the ribs, longitudinal, and you will see this. For any normal patient, you will see this. This is a lung, this is a chest wall, and this is pleural line. Okay. What about this? This is the lung sliding, and you need to just Google it or just go to YouTube and just type normal lung ultrasound. You can see the sliding. Sliding, you will see the movement between the visceral pleura and parietal pleura, between the lung and the pleura. Just you will see the movement. This will be moving like this. Okay. So if you find this finding, this is a normal. I put the normal because you need to know about the normal, then we can go to the abnormal. Same patient, this is the right lung of the same patient, and this is the left lung of the same patient. This is the left lung. This patient, actually, he developed pneumothorax. So in the ultrasound, what do you see in the pneumothorax? This area of the pneumothorax, the area of the pneumothorax, okay? Exactly the probe is here. But you cannot differentiate between lung tissue, no lung tissue here, okay? You cannot differentiate between the chest wall and also very important, you have no any pleural line. This sign called barcode sign.
Barcode.
Exactly, thank you. Barcode sign, okay? Barcode sign. If you find barcode sign, what is that? And why they called barcode sign? Because anything disturbing. Nothing clear. Same like barcode. Here, this area is same like barcode. So no visible lung tissue, no visible chest wall, no visible pleural line. So it is called barcode, and this is definitely one of the findings of the pneumothorax in the ultrasound. Okay, sure, because the pneumothorax occupy the air in the interpleural space, so you will not find any movement between the visceral and parietal pleural. The lung movement here is also disturbed, so you will not find lung sliding. You will not find lung sliding. If you check in the ultrasound, also please go to the Google or to the YouTube and write finding of pneumothorax in ultrasound. It is quite clear. There is no lung sliding. It will be fixed. It will be fixed. No movement. No movement. You will not see anything. It will be fixed. Okay. Also, if you check also in the YouTube, you will find something called comet tail appearance. Comet tail appearance. And the comet tail appearance, just like artificial longitudinal line, you will see in the ultrasound. Later on, we may have ultrasound or focus lecture. We will collect all this video and will be visible. Okay. Anyway, here, the most important thing now is to know about the normal lung, and we discuss it here. Then we discuss sliding, and also we give you the barcode sign here for the name. So this is quite enough for you now. Until we conduct a separate lecture for the focus, anything will be clear. Any questions here in the diagnosis to ultrasound? Any difficulties? For the R1 not using the ultrasound, it will be something confusing because first time to see such imaging such finding. But it's okay. If you have ultrasound, please use it. It is very important to use the ultrasound, and it is very specific and it's very sensitive to diagnose pneumothorax. And also, it may be available more better than the X-rays. Now it is bedside. Okay. If no question, I will go. This is evidence-based medicine. Just overview about the sensitivity and specificity of the X-rays, ultrasound, CT. Always don't take the number as it is. This number depends on the studies and patient to patient also different, but it will give you an overview. It will give you just clear vision regarding the X-ray, ultrasound, and CT in diagnosis of the pneumothorax. For the sensitivity and X-ray is 75.5 sensitive and specific 100%. But it's different because you have tension pneumothorax, you have simple pneumothorax, you have spontaneous pneumothorax, you have secondary pneumothorax, you have primary pneumothorax. A lot of finding. So this sensitivity depends upon the patient, but it's ranging between 75 to 80. It is a range, depend on the patient and depend on the cause of the pneumothorax. Traumatic pneumothorax, not like spontaneous pneumothorax in patient with COPD, for example. Ultrasound sensitivity ranging from 98.1% and ultrasound is specific about 99% in diagnosis of pneumothorax. And specifically ultrasound sensitivity and specificity coming from the studies conducted on the patient with traumatic pneumothorax. So this is a traumatic pneumothorax. So always in traumatic pneumothorax, try to use ultrasound. The sensitivity is better than the X-ray in traumatic pneumothorax. Okay. Regarding the CT, also 100%. This is also depend on the patient and the patient presentation and the underlying lung disease, the primary pneumothorax, secondary pneumothorax. A lot of co-founders here, but it is high specificity. They, as you see here, more specific, more sensitive than the ultrasound and the X-ray, the CT, but not always available. So you can use ultrasound. Ultrasound, you have 98 to 98 sensitive and 99 and almost 100. Okay, although it is operator dependent, but it's so easy. Just now you see, it is so easy. You can practice alone, even you need anyone to guide you. You can just, if you have ultrasound, it is so easy. Open YouTube and practice. Firstly, practice in normal lung, see the normal first, then the abnormal will be easy for you to differentiate. This is about the evidence-based medicine for X-ray, ultrasound, and CT scan. Okay, this is the management. This is the management. And it is very important to know about the management of the pneumothorax. And actually, the management in the tentinally a little bit like confusing also. And you can follow this algorithm. It is very nice algorithm, very simple. I will explain for you and I will break down. It is from Oxford Emergency Medicine. You can check. I try to use it since I was in rotation. It is very, very, very useful. So I will break it for you, okay? See, if you have a pneumothorax, okay, from the beginning, he said for you, if you have spontaneous pneumothorax, bilateral, patient unstable, proceed to chest pain, to chest drain, finish from the beginning. Patient hemodynamic unstable, you have bilateral pneumothorax, proceed to chest drain and finish. Okay. If you have patient, then this is the first thing. This is the second. You need to differentiate. You need from the history. You need to evaluate the patient. Then to know what you will go. You will go here as primary pneumothorax, or you will go here as secondary pneumothorax. So it is very important to know. So we are here now. We are here. Age of the patient, more than 50. Patient had significant history of smoking. Patient had an underlying lung disease. Okay. Or you did just chest X-ray and you find something like, for example, empyema, whatever. If no, consider it's no now. It is no, nothing. Nothing here. Okay. So you will go direct here. You will go here. This is primary pneumothorax. The very thing. So the very thing in patient pneumothorax, you need to determine it is secondary pneumothorax or it is primary pneumothorax. Okay. Now we decide this patient is primary pneumothorax. Okay, we are here. Primary pneumothorax. If the patient had primary pneumothorax, you need to determine two: the size and the symptoms. Okay. If the size more than 2 centimeters, or the patient has shortness of breath, go and aspirate. Go and aspirate. And it is quite clear to aspirate by using 16 to 18 cannula. Aspirate. And try to aspirate less than 2.5 liters just to avoid complication. Okay. And if your aspiration is successful, that means you repeat the chest X-ray and you find the size now is decreasing less than 2 centimeters, or a patient improved symptomatically, then you can discharge. And you give the patient follow-up within 2 to 4 weeks in the OPD. Okay. For example, no, the patient size of pneumothorax, let's go back. The size of pneumothorax is less than 2 centimeters, أقل من 2 centimeters, and patient not symptomatic. No, patient not symptomatic. You will go direct, discharge the patient, and give him OBD follow. So for the patient, for any patient here, for any patient with primary pneumothorax, any patient with primary pneumothorax, young, healthy lung, he came with primary pneumothorax. You need to determine two: the size and the symptoms. If the size less than 2 centimeters, and if the patient not symptomatic, discharge, finish. Give him follow-up 2 to 4 weeks in respiratory clinic. If the patient with primary pneumothorax and the size more than 2 centimeters and patient symptomatic, give aspiration. Aspirate. Okay. And try to aspirate no more than 2.5 liters. Okay. Then repeat chest X-ray. If the size decreased less than 2 centimeters, or if the patient symptoms wise, if improved, so discharge the patient and give him OBD follow. Okay. Shabab, if not clear, please immediately stop me and ask, because this is very important. It will help you a lot in managing patient with pneumothorax. Okay. طيب ركزوا. If the patient primary pneumothorax size more than 2 centimeters and you aspirate it and you repeat the chest X-ray and still the size is same or the size not decreased or the size increased or the patient symptoms wise not improved, so what you will do? You will start
Admit the patient
hmm?
and go for chest drain.
Just drain, exactly. Here you are here, just drain, admission, finish. Primary pneumothorax finished. So we'll go to secondary pneumothorax. You ask the patient about the history. Here we are here now. Okay, we are here. We ask the patient about the history. His age is more than 50, history of smoking, there is lung disease before. So you determine this is a secondary pneumothorax. Okay, same. After you determine this is a secondary pneumothorax, you need to measure the size and to check the symptoms. If this size more than 2 centimeters, if this size more than 2 centimeters, or patient shortness of breath and patient is secondary pneumothorax, you will go directly and to put just drain, admission, finish. Any secondary pneumothorax, the size more than 2 centimeters, or the patient symptomatic, admission, just tube. Okay. طيب. So if the size not more than 2 centimeters, the size is between 1 to 2 centimeters. It is like borderline. The size is 1 to 2 centimeters. Okay. Here, we are here. The size is 1 to 2 centimeters. Okay. Then aspirate. Same like here. Aspirate. Okay. Then after aspiration, already aspirated, the size coming less than 1 centimeter, you repeat the X-ray and the size before it is 1 to 2 centimeter. Now the size is coming less than 1 centimeter. It's good. Successful aspiration, yeah? What will happen? Admission. High flow oxygen. Observe 24 hours. Okay. From the beginning, you check the size. It's no more than 2 centimeter, and patient not symptomatic. This secondary. We are here. Then you check the size. The size is less than 1 centimeter. Okay. Also, admission. So what you observe now, for any patient, secondary pneumothorax, whenever you have successful aspiration or not, whenever you have, regardless the size, the patient is admission. Always admission. Always admission. In secondary pneumothorax, the important thing you need to search for the underlying cause, to manage the underlying cause. And always the underlying cause management and an evaluation always took a long time, more than 4 hours, 6 hours. So highly likely admission. You will admit to check and to search for the underlying cause and to manage. So just to review. I can give you a chance for anyone volunteer. He can just review for us or summarize for us the management. If anyone willing, he can open the mic and summarize. Because it is very important to be aware about it, to manage such patient in the emergency department.
طيب okay, I can try.
Yeah.
طيب الحالة الأولى إنه يكون عندي spontaneous pneumothorax bilateral أو patient hemodynamically unstable. دي طوالي I proceed for chest drain. يعني لو
Very
عندي
good.
bilateral spontaneous pneumothorax أو hemodynamically unstable patient chest drain طوالي. طيب إذا كان عندي primary pneumothorax with a patient less than 50 years old with no underlying lung disease. Either إنه يكون large pneumothorax more than 2 centimeters أو patient breathless أو ممكن نقول hemodynamic breathless. في الحالة دي بقوم بعمل aspiration less than 2.5 liters.
Okay.
If successful يعني السايز بقى أقل من 2 centimeters والclinical signs improved, consider to discharge the patient with follow-up in the outpatient من 2 to 4 weeks.
Very good.
Yes. إذا ما في improvement في الحالة زي دي consider chest drain and admission.
Very good.
Yes. من البداية إذا كان spontaneous عفوا إذا كان primary pneumothorax small size أقل من 2 centimeters في الحالة زي دي
خلاص
consider a discharge.
No, yes, exactly. Okay.
Yeah, discharge and follow up من 2 to 4 weeks. ما قبل كانت كان هو large size more than 2 centimeters. اللي هو aspiration successful discharge unsuccessful chest drain admission. طيب الحالة الثانية إنه هو يكون secondary pneumothorax either إنه هو يكون large size more than 2 centimeters في الحالة زي دي حأمشي طوالي للchest drain and admission أو إنه هو يكون small size
more than 2 centimeters or symptomatic patient symptomatic
or symptomatic. Yes, sorry. إذا كان more than 2 centimeters and symptomatic patient immediately chest drain and admission. إذا كان small size less than 2 centimeters aspiration if successful admission on high flow oxygen. If not successful chest drain and admission.
Okay, very good, very good. I think it is clear now, yeah?
Yeah.
Any confusion from the floor? Yeah, clear. Aisha said clear. Okay, it's okay. So this is the management of pneumothorax. Number primary, you need to determine this primary or secondary. First thing. Second thing, you need to check the symptoms and the size. So why we discuss how to measure the size, and now we know how to measure the size. Then after that, for any patient secondary pneumothorax, always admission. And for any patient primary pneumothorax, always discharge. Unless the primary pneumothorax, after aspiration, no improvement in the symptoms, no decrease in the size, so this patient will be for admission observation. That is. Just overview about, because some confusion regarding aspiration thoracostomy devices. Also this from the intentional diary. There is a lot of method to aspirate. You can go direct by single aspiration, just by needle aspiration. You can put the needle and withdraw the needle and finish. Okay. You can go by small size catheter. Sudan available. This is small size catheter for the chest drainage. Okay. You can go for chest CU. Okay. And even this size, you will manipulate. If the size of the pneumothorax is large, you will go with large tube. If the size of pneumothorax is small, you will go with a small tube like this. So a lot of options you have. The size of, you see here, this is the site to introduce your needle or your chest tube. Fourth intercostal space. Okay, very important. Anterior axillary line. Fourth intercostal space, anterior axillary line. Or mid-clavicular second intercostal space. That is, I think we are about to finish. Probably finish, actually. This is pneumothorax. Any questions? Any questions? Any comments? Any concern? If I forget any important point I didn't mention, just you can highlight it and we can elaborate more. Any questions? Is quite clear? Managing pneumothorax? خلينا نشوف الشات. Clear. Nice presentation. Clear so far. Pneumothorax is simple. Just determine the size. You need to know the size. Very important. Okay, and you need to differentiate between the pneumothorax and pulley. Finish. This is pneumothorax. Size of tube in pediatric. Actually, Islam, pneumothorax in pediatric is very rare. Pneumothorax in pediatric, very rare. كويس. The very thing. The second thing, the size of the pneumothorax itself. You can go with this small size. The size itself, it will determine, not the child. Here, you can go here directly. Small size catheter, less than 40. You can go like this. A small size chest tube, less than 10. You can go there. You see, until 36. And until. This is the size. So the size of the pneumothorax determine the size of the chest tube. Determine the size of the tube. It may be child, but also the size need to be adjusted. Okay. Any other question? Any other question? Osama Din upload the chest X-ray. I think you make this patient Osama Din or?
رسلت صورة أنا تحت في الشات،
ايوه شفتها.
ممكن تديها أنا ما عرفت أجيبها كيف. فالكيس ده كان جانا في
خليه
الشرطة أيام
بعرضها،
الكوفيد.
انا بعرضها لكم. ايوه
أيوه، جانا في الشرطة أيام الكوفيد ميد نايت، وكان عنده ستاب في الليفت سايد اوف ذا نيك، يعني جاي في السوبر سكابولار اريا في الليفت سايد، وما كان ديب، يعني ممكن زي 2 سنتيمتر الون. وكان معي الميديكال يطلب الخير، قال لي ها رايك شنو؟ قلت له خلاص بس نعمل هنا وخيط الجرح ونعمل اكس راي طوالي الميديا. ف ايوه كان في زحمه، وفي نفس الوقت يا هو الشوارع مقفله ونحن دايرين نتعشى، ولا كان الدنيا رمضان ماشيين نجيب سحور. فمشينا في العربيه جبنا السحور يجينا. ففي اللحظه دي هو عمل الاكس راي وجابها. كانوا في ذاك السينيور قاعده في الريسس روم، جا قال لا يا اخي دي الاكس راي بتاعت العيان ده. قالت له لا انا ما ماسك التروما. التروما ماسكه حسام، خلي حسام بعدي.
هو كان الهيستوري بتاعه كان شنو يا حسام؟
ستاب stab wound in the left side of the leg.
Stab, yes. Yes, it's quite clear. Air fluid level there. I think it is massive, massive pneumothorax.
ايوه في سيرفيكال
You did
انفيجن في
chest
النك
tube, yeah?
واضحه برضه.
Pull it, yeah.
ايوه
الفيتالز بتاعت البيشن أو الكلينيكال سيمتومز بتاعته أو البرزنتيشن بتاعه كان كيف يا دكتور حسام لو سمحت؟
هو ينج بيشن جاي اهو كونتاكت اهو اجيتيتد طبعا من الشكل ده ومن البنايه ومعاه ناس وبوليس ودنيا وبتاع هو في الحوادث بتاعت الشرطه يعني. البارامترز بتاعت كويس، السات تمام والبلس حقه كان جميل والبلود بريشر برضه 200.
عشان كده الاكس راي والبيتسايد الترا ساوند، يعني البيتسايد الترا ساوند بتريحك جدا في شكل الحاجات التفاصيل دي.
وطبعا البيشن ده كان في التروما في الشرطه يعني ما دخل الريسس خلاص. الالتراساوند كان احنا خدتنا في الريسس بس يعني. والميديكال بيكون شاد في التروما ويعني نادر كده مرات يشيل الالتراساوند عشان
still the X-ray is gold standing. ممكن. اوكي. طيب نشوف إذا ما في سؤال تاني. Yeah, hematomas. Site of chest tube in the pregnancy. Actually, just you need to go up. Because the diaphragm also, and you need to be in. Still, you need to be in the safe triangle. Just you need to be in the safe triangle. So the safe triangle, as you see, it is anterior border of latissimus dorsi, okay, and the lateral border of the pectoralis major at the level of the nipple. You may go a little bit up, like you can put it in the fourth. But the main thing and the important thing is that you need to be in the safe triangle. This is the main issue. You need to be in the safe triangle. That is. You can go up. You can put in the fourth, no problem. Or even the third, no problem. But not out of the safe triangle. Safe triangle, you need to know about the safe triangle. Safe triangle, you need to know about it. Latissimus dorsi, anterior border, pectoralis major, lower border of pectoralis major, and the inferior border crossing the nipple. So now you are in the safe triangle. You can go for the fifth intercostal, fourth intercostal, and even you can put in the third intercostal, but within the safe triangle. Another question?
السلام عليكم.
عليكم السلام مازن.
يا زنون كيف الحال؟
كيفك؟ تمام والله.
How are you شباب؟ إن شاء الله كويسين.
تفضل مازن.
I just have a little comment about for the chest tube in pregnancy. For chest tube in pregnancy, actually, as the progression of the gestational age of the child. So if the gestational age more than 20 weeks or 21 weeks, with the gravid uterus, it will push the diaphragm up, and that's why you can injure the liver or injure the spleen. So that's why it's advisable to go in the third intercostal space. So you will go a little bit above, sometimes with the progression, even with 35 up to 40 weeks, maybe you can go up to the second intercostal space. And this is actually, it can be guided by ultrasound. And this is one of the benefits, actually. You can do the ultrasound even before the procedure. So even before the procedure, if you suspect it, for example, like this guy, the one with pneumothorax, that you can see actually the effusion, which is the blood in the ultrasound. So you can go by ultrasound guided with aspiration. You will aspirate. If you have aspiration of blood, for example, you can go through the space safely with the chest drain or the chest tube. The other thing you should mention that already, you mentioned that the patient with the stab wound, he had agitation. And agitation, this is sometimes it can be a sign of hypoxia, as early hypoxia. And that's why the patient with pneumothorax or with the tension pneumothorax should have oxygen all the time, despite the oxygen saturation. So that's why it will increase the denitrogenation and it will improve the change in the blood gas change during the procedure itself. So it can optimize the oxygenation more. This is my comment, Shabab.
Yeah, exactly. In pregnancy, because it's the diaphragm going up and the liver and this, and also the gravity uterus. If it is less than 22, as said, by imagine it's okay. You can put like same normal, yeah, patient. But this is gravity uterus, you can go up to the, as mentioned by Mazin, up to second, fourth, fifth, fourth, 3, 2, but you need to be in the safe triangle. That is.
The other
Thank
thing,
you.
Ms. Malish, would like to comment, just to sum up, what are the findings of pneumothorax in ultrasound? So just we need one of the volunteers to summarize the findings.
Well, Shabab, specifically those using the ultrasound. Using the ultrasound in your practice, please just summarize the finding of the ultrasound in patients' pneumothorax.
Decrease lung sliding.
Absent lung sliding, huh?
Absent lung sliding and barcode sign on M.
Okay.
Okay. Anything else?
Lung point.
Exactly.
Lung point, yeah, exactly. So lung point is very important. Why? Because this is the most specific or pathognomic sign for pneumothorax in ultrasound. So if you find the patient with a lung point, this is very specific for pneumothorax. So how you will prescribe the lung point? كيف اللنج point؟ عبارة عن شنو؟
An area where lung tissues which are normal are present and lung tissues which are not present or abnormal are there.
طيب اللي هو بنقول عليها transition. So it looks like a transition zone. يعني from normal lung appearance انت بتشوف lung sliding in one part you can see the lung sliding very well and the other part you couldn't see the lung sliding. And if you do the M mode, you will see half of the seashore sign and half of the barcode sign. Yani actually you can see the both normal and abnormal feature in one image. So this is a lung point. So when you see the lung point, you need to make sure specifically basally. So at the basal area on the basal lungs, you can see the lung point very clearly rather than the upper zone.